Mario.
So I've started recording.
Okay.
Just that.
Okay.
So I can make their own slides. It's usually easier. So I'm not sure who starts.
Mario, go ahead and start, please, for Peru. We'll have you lead off and then turn it over to the other participants with you, Cecilia and Milagros. And then we'll go to the patient perspective with Maria Elena.
Okay. I think I am ready to share the presentation right now. I think this is one. We're ready.
There you go. Thank you.
Hello, everybody. This is the Peruvian team. So we are Cecilia Bonilla, Milagros, Dueñas, and myself, Mario Cornejo, that will share with you a little bit about what is going on regarding rare diseases in our country. So let's start. Cecilia, you start, please.
Yeah. I am a pediatrician, endocrinologist, and geneticist. In this presentation, we will talk about the current situation of rare diseases. For those who have not been to Cusco, this is a picture of Machu Picchu, the sacred city of Incas. The next one, please. Please, Mario, the next one. ¿No se escucha? Mario. Yeah. Peru has a land area of over 1,002,000 square kilometers. It is the 7th most populous country in the region, with over 32 million inhabitants. Current health expenditure in Peru reaches 5.3% of the GDP, below the Latin American average of 7.7% and is far from the 11.9% of the high-income countries. 58.7% corresponds to spending of health and 41.2% to private spending. Of the latter, 84.7% is out-of-pocket expense. In the last 3 decades, the life expectancy of Peruvians has increased by 11 years, today reaching 76.3 years, and infant mortality has been decreased in recent years, 12.6 per thousand. The next one, please. Mario, the next one. Peru is an exotic and diverse country located in Western South America with the diverse climates and great racial and cultural diversity that give it a special attraction for all kinds of scientific and cultural activity. One of the reasons of its great diversity is that the Andes mountain range divides Peru into 3 regions. The coastal region that has more than half of the population, the mountainous region where we can find just under 1/3 of the population, and the Amazon jungle region where the rest of the population dwells. The rugged geography and diversity of the population often produce significant inequalities in access to health. However, these differences have begun to decrease due to the implementation of programs such as the Rural and Marginal Urban Health Service, SERUMS. This is an obligatory program for health professionals who want to do a specialty of or work in a public health center. This program seeks to decentralize the human resources in health by sending health workers to stay for 1 year in remote areas. The next one, please. As you can see from these two graphics, despite the advances of the growth of insured population in recent years, health coverage continues to be below the Latin American average. In the last census, about a quarter of the population does not have any type of health insurance. Then the next slide, please. Peru has a segmented and fragmented healthcare system that includes 5 entities. 44% with the integral health insurance for the Ministry of Health, a insurance for vulnerable population living in poverty. 24.8% with Salud, the contributory social security system for the working population and their beneficiaries. And the remaining 60.2% are the private sector, police, and armed forces. The resulting systems contain several providers of services and insurance, often performing function with a high degree of overlap and little coordination. Today, the national human resources of health density is 70.8 medics for every 10,000 persons. The next, Mario. Sigue Mario.
Okay, thank you, Cecilia. Let's go to the next part. So we are going to show with you a little bit about legislation and policies in our country, in Peru. I think the main law that we are proud of regarding rare diseases was published back on 2011. So this is a specific law for rare disorders. As every law, it needs a regulation of the law, and took about 8 years to February in 2019 to have its regulation. So these are the two main laws that we have in our country regarding rare disorders. Of course, we have another kind of regulations and policies, and we have at this point since last year an official national list of rare disorders. Unfortunately, this list is still not available for everybody to fill out all the registration, but we are in the process right now. So we also have some specific entities that are were created with the idea to analyze and to check, for example, proposals of new or novel, especially high-cost novel treatments for rare disorders. And that is one of our gaps right now, because we are at this point not able to define what we will specifically define a high-cost intervention for rare disorders. So this definition is still in the process. There's a lot of trouble to get this intervention ready for up to now. I think one of the main things that we have right now regarding rare disorders in our country are in this picture. So if you have a rare disorder in Peru, and the treatment or the intervention needed for the management of this disorder is not at higher cost, so you are supposed to define how to help this person or the family according to, there's no specific regulation for that. And so insurance companies and also the healthcare institutions are allowed to decide whatever they consider is the best option for the patient. But in the case you have this high cost intervention or treatment for rare disorders, in our country, we have a specific board, a consulting board belongs to the Ministry of Health that review each requirement and analyze specifically this requirement for every single participant and gives a sort of approval of this treatment. After this treatment is approved and depending on the budget that our Ministry of Health has for high cost interventions, and this part of the Ministry of Health that administrates this budget is called FISAL. Well, you can cover that. So those are the main strategies that we have up to now. So Milagros.
Hi, good evening to everyone. So I'm gonna talk about current national activities and areas of emphasis. About national activities, there is a national newborn screening program that is, as Dr. Bonilla said, we have different healthcare system. So in the social security healthcare system, that have the 30% of the population, they have almost a coverage of 99% of newborns in 4 diseases: galactosemia, phenylcetonuria, congenital adrenal hyperplasia, and hypothyroidism. For the other hospital of the public hospital, there is a national program, but it's improving, and I think the coverage is not more than 30 or 40%. So they are working on that. About genetic service, we are working as the Peruvian Society of Medical Genetics. We are working on the regulation of the genetics units, and there is not a specific regulation, but we are working on that. Also, there are isolated efforts to improve genetics laboratories, including molecular genetics. Most of them were implemented by research projects. There is also a development of policies for rare disease. As Mario said, there is a group working in the National Registry of Rare Disease, and there is a national plan about the implementation of integrated network of service for rare disease. But it's not working, it's just in the plan for the future. There is some training courses for healthcare providers, meetings, symposiums for patients and families. Another areas of emphasis, as Mario said, there is FISAL. FISAL, much of the FISAL budget is allocated to the treatment of cancer. So that is another group that have very high treatment, high cost of treatment. So most of time there is not enough resource to cover the treatment for all patients with rare diseases. There is some dedicated care to some pathologies such as cystic fibrosis, myasthenia gravis, and others. Next, please.
Next.
So this year, as the Peruvian Society of Medical Genetics, we did a national survey of the genetics units. And most of the genetics department and genetic service are located in the capital city, Lima, 84%. Just one geneticist is, two geneticists, medical geneticists are working outside of Lima, one in Cusco, another one in Huancayo. We are almost 30 geneticists, most of us working in public hospitals in Lima. About the clinical activities of the genetics unit, as you can see in the graph, we are in this survey, we have 13 units that answer the survey. So most of them offer evaluation, diagnosis, and genetic counseling. 11 offers a follow-up for different rare diseases, and just 8 of them give treatment for these patients. About the healthcare system, from these 13 units, almost 69% are, so almost 77% are from public system, and just 23% from, 31% from private clinics. About age group, there are some general hospital that can see a patient from all age groups, such as newborn, child, adolescents, and there is another that are specialized reference center, so they just have or can attend a pregnant patient or adult patient or just children's. Next, please. About a laboratory technique, just 10 of the 13 have cytogenetics. So it's important to mention that all these laboratories that do perform cytogenetics are in Lima. So there is not, if we have one patient outside of Lima, they don't have cytogenetics. So they have to come to Lima or send the sample. About chromosome fragility, just 3 of the 13. Fish, just 3. 2 of them are public and the other is private. About PCR, conventional PCR, just 6 of the 50%. There is another technique, but just in few laboratories, like chromosomal microarray, Sanger sequencing. There is just 3 for medical genetics service, and 5 NGS sequencing in the country. About cytogenetics, for example, for the type of sample, 10 of the 13 perform karyotyping in peripheral blood, and less than 50% perform cytogenetic from another kind of sample, like abortion, remnants, amniotic fluid, solid tumors, bone marrow, and others. About gene test for using the PCR techniques, there are some that you can see in these slides. So these are just target mutation for this gene in disorder of, for example, spinal muscular atrophy, Fragile X syndrome, cystic fibrosis, achondroplasia, and others. About oncohematology, there are some point mutation mainly in oncohematological disorders, leukemia, acute leukemia, myeloid disorders, and others. And in neurogenetics, there are target mutation and these studies for Huntington disease, Duchenne muscular dystrophy, another muscular dystrophy as Steiner disease, another neurological disorder. I said Mario will tell us later. Next, please. And for these are another tests that are performed in all the countries. So there are very few laboratories that perform these tests, and there are just specific genes that are studied. These are for real-time PCR, Sanger sequencing, Mosogen for leukemia and hematological cancer, and NGS, some gene panels. I think most of our patients that requires a genetic test, for example, a gene panel or an exome sequencing, we just collect the sample and send to international laboratories. Sending sample for example, for Invita, that is a US laboratory, is cheaper than performing that test here in Peru. Next, please.
Cecilia. Cecilia.
Sorry. As a country, we have many challenges of tackles and needs, especially in rare disease. The Peruvian Ministry of Health estimates that 2.5 million of Peruvians suffer from rare and orphan diseases, but that data is not exact. This is because even though a registry has already been created by law, in practice, it still doesn't work. One of our biggest challenges is centralism that could be considered a blessing or a curse. A blessing because having the highest concentration of the population and human and technical health resources in the capital city and the cities of the coast, we can ensure better health coverage. But it is a curse because there is an unequal geographical distribution of health workers. The most remote population have much more difficult access to health services. Our fragmented health system, with its different rules and budgets, does not allow exchange of services in areas where one is present and the other one is not. Also, it doesn't allow centralized purchases of drugs and devices. These purchases could lower prices and allow a better access for the effects. An attempt is being made to create a unified health insurance system, but it is still far from being obtained. Sadly, in our country, there is little communication between health managers and those who care for patients, so that in many opportunities, the rules do not adapt to healthcare reality. A clear example for this are the legal regulation regarding rare diseases that define these as those that have a frequency equal to or less than 1 in 100,000, when the World Health Organization defines them as 1 in 2,000. This leaves out the norm and the benefits that it can have, precisely the most frequent rare diseases. Unfortunately, the lack of training and the difficulty in accessing diagnostic support services in rare disease, and especially in inborn errors of metabolism, causes a delay in the detection of these diseases by primary care physicians and even by pediatricians, which is detrimental to the patients. In addition to this situation, there is a limited number of geneticists, as Milagros said, approximately 30, of which only 2 are outside of the capital. Another issue that affects the managers, a large number of non-specialist doctors, and the patients themselves, is that they are unaware that there is a diagnosis and treatment for the problem that affects them. One of our greatest challenges is the lack of public genetics laboratories, as Milagros said. That characteristics in the country, which makes the diagnosis very expensive. It is also important to mention that many orphan drugs and medical foods are not registered or available in Peru. Despite the efforts made by the Ministry of Health in favor of our patients, the pandemic delayed any advances, and in the National Registry of Rare and Orphan Diseases, data is not available yet, and therefore there is no entity doing to follow up of patients. On the other hand, the patients compete for the budgets, as Mario said, of FISAL, a Solidarity Health Fund in charge of healthcare for people affected by some disease of high cost. This situation is to be corrected with the update of the list of rare diseases issued in 2020, which include 546 diseases without priorities. We are also missing many clinical practice guidelines. Our work is basically healthcare in most health establishments, and the time for research and bibliographic review is limited. So the production of the guides takes more time than usual. Finally, for all these reasons, patients also have limited access to genetic counseling. Mario?
Thank you.
The next, Mario.
Okay, let's go for the next section about the needs of policies on legislation, on research and healthcare services. So regarding research, as Cecilia and Milagros mentioned, limited funding opportunities for studying rare disorders are the rule in our country. So there's a need about the specific aspects of collaborative research. For example, we do not have a specific legislation for data or material transfer agreements. We are starting to performing this for some big collaborative disorder research. However, our government is trying to compile everything, and I assume that we soon will have Peruvian legislation regarding that, because at this point we usually only use the forms that are international research groups send to us. There's no explicit regulation for sharing biological samples with alien institutions as well. So regarding healthcare services, there's a need of universal policy across subsectors. As you realize, in our country, we have 5 different subsectors on the healthcare. So that's a kind of a mess, mainly in rare disorders. So we need a national registry for rare disorders. Still, we are working on it, so hopefully we will have that soon. We need an expansion of available tests for rare disorders. As Milagros just mentioned, we have limited capacity for diagnosis of rare disorders. We need implementation of referral laboratories to preventing sending samples abroad, at least not all of them, and to make a more efficient use of the local capacity. We have capacity, but I think we do not use the capacity that we have available in country in an efficient way. The registry of orphan drugs and having a bank of drugs is also a need, as well as the mechanism to increase access to medical food and other organ drugs for patients. And regarding opportunities for future collaboration about healthcare, I think there are a lot of things we can consider for collaboration. So most of the national centers follow a large number of cases and families with rare disorders. I think it's quite interesting, quite important to collaborate in a first step among us and among the Peruvians, and obviously with Peruvians with the rest of the world. There's a need of confirmed diagnostic procedures. We need diagnosis. Some of our patients are still without formal diagnosis. We need remote genetic counseling, for example, programs. The medical geneticists are prepared and well trained on genetic counseling, but there's not enough, and there's no postgraduate program for genetic counseling in our country. So telemedicine also is an excellent tool for monitoring patients, and probably we can use telemedicine also as opportunities for collaboration with other centers, training opportunities as well, and use ERCAL probably to try to establish a Latin American clinical practice guidelines or something like that. Regarding research, you know, as Cecilia mentioned, the Peruvian population is a unique ethnic population with an average 70% of Amerindian ancestry, and so that is kind of huge interest for every single genetic study in the world, because we really need to have a proportion of different types of population, including Amerindian population, in every single study that is currently ongoing. So clear and robust legislation for clinical trials. Probably for other kind of studies, we still are struggling, but for clinical trials, we have a very strong and clear legislation. And so I think that's a big plus. And IRB committees are with growing expertise on international collaborative studies as well. And we are starting to develop local research networks as well. Milagros?
Yes, about the suggested activities for Peru and Latin America. for a sustainable ERCAL. Maybe we can propose an annual ERCAL meeting, including abstract call for all ERCAL participants, broad agreement of mutual collaboration about ERCAL partners, clinical discussion, diagnostic network for rare disease, ERCAL website with researchers, clinicians, patient, families access. Next, please. This is the hospital where I work. Is the Edgardo Rebagliati Martins Hospital. This is the main hospital of the Health Social Security. It's located in Lima. I think it's the bigger hospital, general hospital. The country, it has 1,500 hospital beds and have almost 7,100 births per year. This is a national reference center. It's a center of expertise for the diagnosis and treatment of rare disease in the country. The genetics clinic is available for all age group. We can see outpatients care about 100 to 300 cases per month, and inpatients care 8 cases per month. We also are participating as a member of the Latin American Collaborative Study for Congenital Malformation. Next, please. Next, okay. So as part of this Latin American study, we have a surveillance for congenital malformation. We are planning to have a surveillance for rare disease in the hospital for inborn error of metabolism and lysosomal disorders. And also we are working with an undiagnosed disease program with the collaboration of Illumina that give us to our patient the possibility to do the genome, family genome for 50 families in the 2020 and 30 cases, families studies for this year. Next, please.
Thank you, Milagros. So for the neurogenetics part, I just want to mention that we have a neurogenetics division, part of the National Institute of Neurological Sciences, one of the 7 institutes of health based also in Lima. So in our center, we are concentrated in a specialized center for clinical care for Huntington's disease and other types of repeat expansion disorders, including spinocerebellar ataxias, myotonic dystrophy type 1, inherited neuropathies, and also many kinds of muscular dystrophies as well. We mostly concentrate, are mostly concentrated in adults, but also we have a bunch of people under 18 years of age. We are a mixed center because we combine also healthcare with research, and so we have a national neurogenetics research center, and we have ongoing research projects regarding the genetics of Parkinson's disease, genetics of dementia and Alzheimer's disease. We have a funded study for SCA10 right now. We have the very first DNA bank of the country in our center. And we also have a very nice community program for taking care of people living with Huntington's in the Cañete Valley, a small town 2 hours bus distance from the capital city. And finally, Cecilia.
Yeah. Finally, I want to tell you that I work at the San Borja National Institute of Child Health, National Reference Center for Children, in which we have many fields of work, such as oncohematological disease, bone marrow and organ transplants, which already have an approved budget that support them. On the other hand, we have other clinical areas with little support, which have great importance for patients and their families, and can become wonderful opportunities for collaboration. Inborn errors of metabolism is early diagnosis, and its early diagnosis and treatment is transcendent for the life of patients and their families. In some cases, it means that differences between life or death, and in others, the existence or not of disability. Disorders of sexual differentiation, DSD, are a group of disorders that can affect gonads, internal and external genitalia. In an important group, it is difficult to make a diagnosis using cytogenetics techniques and hormonal evaluations, requiring molecular diagnosis to clarify the patient's condition. Treatment and give genetic counsel. Exact diagnosis of DSD is extremely important for self-image and gender identification. It is especially important to establish alliances between the countries of the region that have possibility to help with diagnostic tests. Additionally, it would be very important to establish collaboration network with international organizations as NIH, Pan American Health Organization, World Health Organization, UNICEF, ICOR, G2MC, to help us with molecular diagnosis and provide initial assistance for treatment for patients with rare diseases, while we get them through our health system. This collaboration will also allow us to know the frequency and distribution of these disorders in our country. We believe that ERCAL could help us. Thank you.
Okay, thank you very much. I'd like to hold the question, if we could. We wanted to get the patient perspective, and Maria Elena, I believe, is ready to go. So if we could hold question, but first, thank you very much for preparing a very thoughtful and thorough presentation. I think what you presented this evening really does summarize many of the problems that we've confronted thus far. So thank you, and we'll be back in touch here after Maria Elena's presentation, if that's okay.
That is fine. Thank you.
Thank you very much. Thank you, Mario. Milagros. There you go, Maria Elena. Thank you very much. You're ready.
No te escuchamos. María Elena, no te escuchamos.
Tu audio.
Ahorita.
Ahora sí.
Yes, and I think Maria Elena is going to present in Spanish.
It's okay.
Slides will be in English. Is that correct?
In Spanish.
Okay, very good. Thank you.
Hola a todos, mi nombre es María Elena Almendaris, soy directora ejecutiva de la Federación Peruana de Enfermedades Raras. Bueno, les envío un cordial saludo de María Lourdes Rodríguez, presidenta de la Federación Peruana de Enfermedades Raras. Y un poco la ley para las enfermedades parte en el 2006-2007 donde un congresista nos visualiza la necesidad de que exista todo un marco legal y regulatorio. La necesidad es recibida por el presidente de la República. Iniciamos todo este proceso, ¿no? Se crea la ley 29698 a cargo de la Presidencia de la República y se entrega a la Federación. No existía en ese momento la Dirección de Enfermedades No Transmisibles. Se promulga el Día Nacional de Enfermedades Raras. Luego avanzamos con el tema de la regulación de la ley 29698. Adicionamos a esto el tema de los primeros screen neonatales para las patologías que ya han mencionado. Hay una más de las 4 que han mencionado. Y el punto número 5 fue muy importante para nosotros para modificar la prevalencia. Antes se consideraba 1 en 100.000 y logramos que consideren 50 sobre 100.000 habitantes. Para desglosar el CIE-10 en cuanto a las patologías, tomaron la data de las patologías de la Federación, incorporaron a la data de MINSA y se logró obtener 473 códigos. Luego se encontró 20.000 pacientes, un poco más de 20.000 pacientes registrados en MINSA, y finalmente luego se logró aumentar esta lista hacia 546 códigos, y la próxima extensión a la orden de 100 códigos será hacia enero del 2023. También dentro del plan y la reglamentación está el desarrollo del modelo para la atención en el curso de la vida de la persona y la familia, una dirección nueva que aún está en proceso de desarrollo, no ha tenido presupuesto, esperemos esté funcionando en el transcurso del año y el próximo año. Se creó la red de evaluaciones de tecnologías sanitarias solo para enfermedades raras, a cargo del Instituto Nacional de Salud, la Comisión Consultiva para el Diagnóstico y Tratamiento, y finalmente llegamos al Plan Nacional para el 2021-2024, que ha iniciado recién en marzo del 2021. Se han encontrado 7.000 pacientes nuevos en MINSA y se está desarrollando una estrategia para incorporar presupuesto para poder atenderlos. En las actividades nacionales encontramos que 546 códigos se ha encontrado un desglose de 1.207. Luego tenemos en la formación de la red de evaluación de tecnologías sanitarias, ya tienen su software especial para el control y monitoreo de estas evaluaciones. La comisión consultiva ha recibido en marzo sus 2 primeros expedientes. Y en cuanto al Plan Nacional de Prevención y Diagnóstico, en el 2021 principalmente son desarrollo de capacidades. También tenemos el inicio de la capacitación para personal sanitario en algunas patologías. Todavía no se ha lanzado el Registro Nacional de Pacientes, es un aplicativo nuevo que se ha creado, ya salió de la Oficina de Calidad. Esperemos que esté activo entre mayo y julio. Y finalmente no se ha determinado el umbral de alto costo para tratamientos de alto costo para la evaluación de tecnologías sanitarias, pero se habla hasta el momento de cerca a 10.000 soles por medicamento por paciente al año. Dentro de una lista larga de actividades que desarrolla la Federación, bueno, hay una que sí se ha visto detenida, sobre todo los diagnósticos descentralizados a nivel nacional, donde viajábamos a ciudades de provincia con un grupo de médicos y enfermeras para poder encontrar más pacientes, y encontrábamos cerca de 100 a 75 pacientes por cada ciudad. Es imposible no hablar un poco del sistema sanitario para una población de 32 millones de habitantes. Aproximadamente 45% de la población con enfermedades raras se encuentra en Lima y el 55% distribuido en el resto del país. Existen alrededor de 2 millones no registrados todos, y cada una de estas regiones, que son 24, tienen un nivel individual de gobernanza, gestión y presupuesto. Aunque muchas veces estos gobiernos no ejecutan todo su presupuesto, inclusive no reembolsan las prestaciones a los proveedores de salud. En cuanto al nivel de atención, tenemos que el sistema público tiene el 95% de la población entre estas 3 prestadoras de salud, que es SIS, Salud y las Fuerzas Armadas. Actualmente tenemos 27.6 médicos por cada 100.000 habitantes, 1.3 doctores por cada 1.000 habitantes, 3,8 doctores por cada 1.000 habitantes en la ciudad de Lima, y en las ciudades más desprotegidas 0.7 médicos por cada 1.000 habitantes, como Piura, Cajamarca, Loreto, entre otras. Finalmente, para llegar a que hay pocos especialistas concentrados en Lima y no están distribuidos en provincias. Un poco en cuanto al sistema de salud y las enfermedades raras. En general, los 32 millones de habitantes están 62% en SIS, 33% en salud y el 5% en otro. En cuanto a enfermedades raras y el registro, que no está consolidado, se encuentra 86% registrado de salud, tenemos 14% en SIS, en la data de FPR dice que alrededor de un 72% se atiende a través de salud. En cuanto a las compras para medicamentos de enfermedades raras, salud ejecuta el 94% del presupuesto y SIS 6% de este. Finalmente, para de salud, el 18% de su presupuesto lo utilizan en medicina para enfermedades raras y le representa 1% de su población total registrada. Y SIS ejecuta 0.75% de su presupuesto y para atender al 0.14% de la población total registrada. Solo existen 32 medicamentos para enfermedades raras específicos, 4 de ellos de alto costo, y son atendidos principalmente por eSalud. Un poco entre las barreras, los obstáculos en la fragmentación de este sistema territorialmente a nivel de gobernanza, de armonización de farmacias para estas prestadoras de salud, falta de especialización y descentralización de los médicos, y toda la articulación y gestión, ¿no? Una falta de capacidad para esto. En cuanto al desarrollo de capacidades, falta de desarrollo de capacidades en cuanto a las enfermedades raras en el personal sanitario, el registro es poco, malo, y no hay conocimiento correcto de la codificación. En cuanto al acceso a medicamentos, la dirección de medicamentos es categoría 2, tiene un bajo estándar, poco personal, baja capacidad de gestión, los procesos no son ágiles ni transparentes, y los medicamentos actualmente se compran a 150 a 1500% de los valores internacionales. No hay una armonización para el acceso a los tratamientos. También nos vemos enfrentados a que permanentemente hay un cambio en los altos funcionarios, sea ministro o altas direcciones, cada 4 o 6 meses son nuevos, lo cual no permite avanzar en el desarrollo de estas políticas públicas. No se han determinado los centros de referencia para enfermedades raras, y también se necesita, en cuanto a la legislación, compras centralizadas a nivel de Perú para ser distribuidas a las prestadoras de salud, inclusive involucrar a la Ministerio de Relaciones Exteriores, a la Cancillería, para hacer compras bilaterales o compras a nivel de Latinoamérica para optimizar estos presupuestos. También se necesita, de pronto quizás contratar, como lo hacen otros países, personal externo para las evaluaciones de tecnologías sanitarias, y un marco legal formal en la participación de la sociedad civil. Falta modelos de gestión y atención para pacientes con enfermedades raras. No hay articulación a nivel de Latinoamérica para estas necesidades, tanto en la investigación. Podríamos promover en Perú quizás una ley de medicamentos vitales no disponibles, como el caso colombiano, y se necesita expandir toda la parte de evaluaciones de screening natales y la parte genética. En oportunidades de colaboración, bueno, la DIGEMI necesita actualmente mucha asesoría técnica. También podría desarrollarse interoperabilidad transnacional de guías de prácticas clínicas, farmacológicas y equivalencias, hacer fast track de algunos procesos que nos encontramos muchos países en Latinoamérica haciendo exactamente lo mismo. Tampoco hay capacidad para las evaluaciones de tecnología en cuanto al multicriterio. Se necesita mucha capacitación en el personal sanitario, incluso en los estudiantes, y en el manejo de la data de enfermedades raras. Se podría promover consultas internacionales para el tema regulatorio en cuanto a las consultas de priorización de medicamentos, y el plan nacional actual estipula una red colaborativa nacional e internacional que aún no existe formalmente ni estructurada. Nosotros sugeriríamos que dentro de las actividades compartir las mejores prácticas. El gobierno peruano necesita una asesoría técnica en la base de datos. También necesita entrenamiento, sensibilización para el personal y estudiantes. Se necesita mucha articulación de las iniciativas para el acceso a tratamiento y diagnóstico dentro y fuera de Latinoamérica. Se necesitan las mejores prácticas para armonización en el acceso y adaptarla a esta nuestra realidad. y todo el tema de las mejores prácticas para las compras conjuntas, como se desarrolla de pronto en Europa, que no existe esto desarrollado a nivel de Latinoamérica. Muchas gracias.
Mil gracias, Maria Elena. So maybe I'll start off with some questions and to warm things up a little bit. So some of what I heard reminded me a lot of what I experienced in Ecuador. So if you're at a public institution, spending money, compras públicas, is an insanity. So purchasing reagents for diagnostics, purchasing diets for patients, purchasing medicines, at least in Ecuador, but it sounds like it might be the same in Peru, was an incredibly complicated system. Of course, there was a reason for this, and that reason is called corruption. But compared to other countries, buying stuff at a public institution in Ecuador was incredibly difficult. And from what I've heard from Peru, that might also be in Peru. What do the Peruvians think? And we got stunned silence. Okay, so let's leave that aside then. I guess the other issue that struck me, again, talking about money, I think it was called FISA, the board that allocates money for treatments, diagnostics, and so on. Am I to understand that it's one huge pot of money and everything goes out of there? So there's no specific money allocated for cancer treatment or rare diseases. Everyone is competing for the same amount of money. Would it make sense to basically create a pie chart and says, this piece of the pie goes to cancer, that one goes to heart disease, and this one goes to rare diseases?
Well, that sounds reasonable, as you mentioned, but that doesn't happen right now with FISA. As you mentioned, there's only a unique fund for everything, and this competing is not equitative. It's not equitative at all, and seems to us this is our perception that cancer looks like the most part of the pie.
So, okay, so thank you for that, Mario. So I'm of course also thinking a little bit politically here, and I guess some things are easier to say as a gringo than if you live there. But so one way to increase funding is to have a pie chart and then point to the fact that, look, we have 2 million people with rare diseases and they're getting so much of the pie while cancer gets this much. So some of it, of course, also is about politics and convincing politicians, legislators, ministers to allocate more money, in this case, for rare diseases.
Hi, this is Jose Josan from Peru. Yes, you are right. All the budget is oriented to cancer diseases for these high cost diseases. But I think that it is a very good opportunity to have the regulation today, but the most problematic is not necessarily have the strategic planning in order to apply the reglement for the rare disease. So, however, we are working with the Minister of Health. I'm part of the FEPER. So we are working in this field in order that increase and spread the budget for different alternatives or maybe strategy like oriented the budget for other ministers, not only for the Minister of Health. For example, Minister of Work or Minister of Economy directly. So I think that in this moment we are in a very strategic moment for the relationship between Ministry of Health and rare diseases.
Yeah, there seem to be many changes that were occurring, and that looks like historically, that looks like a good sign that things will be changing.
Yes.
And I think it's really, really important to nurture that relationship because
yes,
I think even historically, as I look back at what happened here in the United States many years ago, both in research and payments, always a greater deal of emphasis has been on the cancers. And but what we tried to do was then provide that emphasis not only to all the cancers, but specifically to many of the rare cancers and the inherited cancers. So
yes.
things can change as you go along, but it looks like you're making some very good progress.
Yes, I think so. But this is the result of the hard work of the civil society, of the patient society. Yep. So we enjoy the results, but it's behind of that is a strong work for patient and family of the patients. Eh?
I think we all would agree that in most of our countries, we would not have orphan drug acts or orphan rare disease legislation or anything without the strong patient voice supporting the research community and the industry and all of the partners involved with rare diseases. So yes, you're absolutely correct.
There was another thing that struck me, which is not an unusual problem, and that is there was a maldistribution of medical professionals across the country. So they tend to be concentrated in metropolitan area, and I think my recollection was like 45% or something were in Lima, and the rest of the country got the rest, or for medical geneticists, I think it was even worse. So here in Australia, there has been an interesting experiment that is about to start. So here there is also a maldistribution of doctors. And there is a national health system, which is called Medicare. So it's different from Medicare in the US, but there is healthcare for everyone. It's provided by Medicare. And what the government will now consider doing is to increase the amount of money people get if they practice medicine in rural and remote areas, as opposed to the big cities. So of course, most doctors will live in Sydney, Melbourne, you name it. But so in the bush, there are a few doctors, and the money that doctors get for providing services to Medicare is now being discussed to be higher if you are in rural and remote areas, as opposed to a metropolitan area like Sydney or Melbourne. So there's an economic incentive to have doctors, including medical geneticists, but also GPs in rural and remote areas. And so the question is, ideas like that would also work in Peru or other Latin American countries.
I want to comment also on one of the slides. It talked about and you know, we've all talked about undiagnosed diseases, but Dr. Domenica Tarusio is on the call right now too, I believe, and we would be happy to provide the link to the Undiagnosed Disease Network International to foster that collaboration, yes, which is growing around the world. So Domenica.
Yeah, I'm here. Yeah, yes. I would like to comment. In fact, I was really interested in this point, and I may contact the colleagues and yeah, to invite to collaborate with the Undiagnosed Diseases Network. So maybe we can contact each other through Professor Steve Groft and join the UDNI network. Yeah. So we will share our expertise and activities we are doing in this such beautiful and interesting network. So we will follow up on that. Yeah, Steve, thank you.
And
Steve?
Yes, go ahead, please.
Thank you very much. First, I would like to congratulate all the colleagues from Peru for such a wonderful presentation and well coordinated. Yeah, I am very impressed by the developments that have happened recently in Peru, because although there are some difference among the countries in Latin America, it seems that we are catching up now in many aspects of rare diseases. And I want to thank the speakers for trying to concrete suggestions about the joint work between ERCAL and Peru and the other Latin American countries. It's obvious from your presentation that there are a lot of things that can be done together among us, and that some of us have weakness and some other strengths that can be shared. And at the final, you show us that this cooperation is well needed and may be very fruitful in a short time. I have a question because I would like to learn from Peru. You said that you got 99% coverage in a newborn screening. Is that all right? Because
Yes,
if that
for
is so,
just the Social Security healthcare system, just for one of this system,
okay.
not for national.
For one? Yeah. Okay. Because if that will be the case, it will be a kind of a lesson for all the Latin American countries, because all of us have the same geographical barriers and difficulties, and it's not easy to get 100% coverage in Latin America. You show that also for all the genetic diagnosis. We in Latin America, we have all those common problems that you show. To some extent, some are, as I said, a little bit ahead, but the good thing is that if I look at Peru, I can see in a way reflected also the Colombian situation. And thank you for inviting us to collaborate. And there are many things that you mentioned that are really waiting for us to get together, like the guidelines for these rare diseases, also the reference centers, education, and all those things. We can help each other. And again, my congratulations, my thanks for the work you did. Thank you very much.
Hello from Peru, from FEPER. Just to take some minutes, I'm a Neil Townsend member of the board. Our executive director is Maria Elena. I am a mother of a young boy with Duchenne. What I wanted to congratulate our great physicians. In Peru, we have very good doctors. What we need is much more, of course, knowledge and budget to make a massive attention. But I wanted only to point out that ERCAL is a great space to connect with policy and lawmakers in Latin America and the Caribbean. We have partners like federations in other countries, but in the case of Latin American Parliament and the League of Parliamentarians from the OAS, Organization of American States, I think it will be important, because when you get common laws, not because they are mandatory like in the European Union, but they are recommendations. We have experience of how models of laws and policies in Latin America will impact in our parliament. So from FEPER, we learn, of course, mainly by the 10 years they work. I have been integrated recently, but in this activism of many civil society organizations and physicians and doctors, as the Peruvian ones that have been present today and have showed their high quality or professional quality, it is important to highlight the impact in policymakers, which means executive powers, regional governments, and parliamentarians. That's something FEPER is developing a lot, and also the ministers of foreign relations. Now in the situation of the vaccines, we are learning how these foreign ministers are very important to promote technology and medicine. I have the Maria Elena tells me also to let you know we are grateful for the invitation. We have a scientific like Jose Josan also, and we are very happy to have been with you. No?
Thank you. We did have a question that, and mostly to receive comments from the speakers perhaps, that Peru recently published their national plan for rare and orphan diseases. And if there were any opinions on this plan or any discussion of the content, any comments at all from any of the speakers or any of the other participants?
¿Cuál es?
Sí, la pregunta es, soy Javier Guerra, la pregunta es, recientemente se ha publicado el Plan Nacional para 2021-2024 y quería saber qué valoración tienen de este plan, si va a ser suficiente o, bueno, pues un poco cuál es la valoración que se tiene de este nuevo plan.
No sé si alguien va a responder o Anel, tú me das un soporte y yo respondo.
Yo creo que deberías responder tú, María Elena.
Bueno, o si no, José, me
Ya,
ayudas.
ok.
En realidad,
María Elena, contesta y yo te doy el soporte.
Bueno, en realidad el plan nacional para este año tiene principalmente desarrollo de capacidades, ¿no? Tanto de las entidades nacionales e internacionales, tienen capacitación del personal en enfermedades raras a nivel internacional y a nivel local. Esas son las actividades principalmente para este año. Si tuviera que decir algo de este plan, es que lo que le falta mucho es velocidad, ¿no? Es un plan bastante lento en su funcionamiento, ¿no? Y sumado esto a la pandemia no avanza como quisiéramos que este avance. Y el desarrollo de guías farmacológicas para enfermedades raras también debería acelerarse dentro de este proceso, ¿no?
Lo traduzco. She considers that we consider, as FEPER and our executive director is saying this, that the national plan content is focused in the training program for public servers and para servidores públicos y también sociedad civil, ¿no? De entrenamiento.
Sí.
Training and also that the plan is of a slow execution. So we need much more, as we were mentioning before, much more commitment from the policymakers, public servers to get through it. Hablaste de una guía también, ¿no?
Sí, hablan de una evaluación para medicamentos farmacológicos para enfermedades raras, de la guía farmacológica, y cómo van a desarrollar un medicamento para pero no hay cuándo llega, ¿no? No hay cuándo llega.
So there's a plan for a guide of pharmacological products, but the time is slow and the execution capacity also. So it means that we are prepared, but we know not necessarily we have the people who is more familiarized or maybe more committed with this situation. So it is important for us. Just an example, we have done a united work right now between associations regarding Down syndrome and rare diseases, genetic diseases to get into the phase 1, part 1 of vaccination. And we got it through a coordinated work regarding executive power and parliament and media. So people with rare diseases will get vaccinated before July, before the change of mandate of this government. And in the international way, we gave examples of Colombia, Spain, United States, as countries that were, and Chile, ahead of us with the vaccination of vulnerable rare diseases condition. Mm-hmm. Thank you.
Thank you.
Can I reply in Spanish, please?
Yes, please, Cecilia.
Yo le ayudo, doctora. Usted va hablando, si quieres, me ofrezco.
Perfecto, gracias, Anel. Quiero aprovechar justamente que tú tienes mucha cercanía con políticos y gente influenciable en el país para decir que sí, estamos preocupados por las enfermedades raras, tenemos interés en capacitar, en implementar el registro para hacer un buen seguimiento de nuestros pacientes, y eso es maravilloso para tener una data y tener una idea de lo que pasa y de cuántos somos y todo eso que no está del todo claro. Pero...
Okay, the Dr. Bonilla, she says, primera parte, espere para darle traducir.
Okay. Okay.
Dr. Bonilla is saying that physicians, scientifics like her are worried about the implementation of the national registration of the patients and to get the training programs for the people that should be educated about the condition, but she was going to add another aspects. A ver, ahora otro aspecto, doctora, que ya le traduje la primera parte sobre el entrenamiento, el registro.
Perfecto. Entonces, pero yo creo que una parte importantísima en lo que tenemos, en los que cuidamos de este tipo de pacientes es ver la parte económica. Tanto los alimentos médicos, que son los que se usan en errores innatos del metabolismo, como los medicamentos, los reemplazos enzimáticos que se usan en otro tipo de estas enfermedades, son sumamente caros. Y parte de lo que encarece los productos son los aranceles, los impuestos que tienen. Entonces yo creo que una buena cosa que pueden hacer nuestros políticos, Anel, es que así como se ha exonerado impuestos en productos oncológicos y en productos para SIDA, para VIH, deberíamos tratar de exonerar estos productos que van a proteger a mucha parte de la población, sobre todo a niños, ¿no? Que podrían tener un futuro brillante y que no pueden acceder a ello porque el medicamento es muy caro y con gasto de bolsillo es prácticamente imposible. Una lata de alimento médico acá llega a costar alrededor de $300, una lata. Entonces es sumamente caro.
Terrible. So, Dr. Bonilla is saying that this is an...
Quiere hablar, sí. Lo de los alimentos ya lo hemos solicitado.
Pero María Elena, termino de traducir a doctora Bonilla y de ahí a ti.
Ya. Bueno, solo decir que ya lo hemos solicitado nosotros, lo de los alimentos para como 10 fórmulas,
ya, solicitó. Como FEPER ante MINSA, ¿no, María Elena? Se ha oficializado.
La República y Ministerio Económico.
Yeah. Well, it's good information coordinated by what the perspective of Dr. Bonilla, who she is in contact with patients, and Maria Elena as a executive director. Maria Elena, she didn't mention it, but also she's part of the mothers of young people or children with rare disease. Dr. Bonilla was saying something which is true, of course, which is more than true, is a very worrying situation, which maybe we share with other countries, the high cost treatments because of the taxes we have to pay to get imported medical products, which some ones are nutrition products that can cost only just one unit, $300. So as I think other doctors mentioned, and also Maria Elena, we have FISAL, but FISAL versus cancer is very rare diseases versus cancer in this case also suffers from very little budget. So now we are in a situation in which we have elected a new parliament and we are going to elect a new president. So it is very important to get through these institutions. FEPER as a federation has presented this to the current authorities, and we wish this will get better. Dr. Bonilla mentioned I am linked with politics. Yes, I have been in the parliament for 10 years, but the last time I was there was in 2006, but I can share with you that this is a matter that if you talk to all the parties, there will be more acceptance. It's not a political complicated situation. What we have to see, it is against discrimination and against letting people without attention, especially after this experience of the COVID-19. So I think nationally and regionally and internationally, we can do a work. I was part of the parliament when we approved benefits for the import of products to battle against cancer. So I think rare diseases can do this. The special commission about disabilities, which include people with rare diseases, began in 2001. I was part of it. And at that time, the Ministry of Health didn't have much budget. And they told us, I have to take care of tuberculosis and of high, this is lung infections because of low temperature in the Andes. So it is difficult for us, the MINSA said, Ministry of Health said, to take care of rare diseases. But 20 years have passed, and even the budget for the ministry is not as enough we want to be. It's more, and it should be focused in this case. No? So Dr. Bonilla was highlighting the fact of the need to introduce into laws of exemption of taxes, the situation of the high cost treatment. And Maria Elena was informing that officially we have asked for this, and we can work together with all these great people and doctors that have expressed their experience and recommendations, as Dr. Bonilla, Dr. Dueñas, and I don't want to miss anybody, no, but Dr. Cornejo, I think. So in my case, my son goes to a salute, and I can tell you, doctors are very interested in taking care of this situation.
Okay, thank you very much. I think we're coming up to almost 7:30, so we may have to end it at this point in time. Bolivia was going to present tonight. They asked to be rescheduled to later on, and so we did make plans to move them. I think it's maybe July 20th or something like that, but we'll reschedule. And our next session for ERCAL will be on May 25th. And at that time, Mexico and Paraguay will be presenting. I think what we're looking at, we've been trying to get 2 countries in to each session, but there's so much going on in many of the countries that we are seriously discussing just having 1 country per evening, and then perhaps even extending the time. So we do have adequate time to connect with each other and to talk and have questions with answers coming. So I don't know what else to say except thank you so much. It's been a pleasure working with everyone in the last several weeks, trying to arrange for the coordination of the presentation. But but I'm really grateful that everyone came together and worked as a team. And I think you saw in the quality of the slides and the presentations that you had a commonality of thought and thoughts about what is needed and how we're going to work as an organization, how we're going to work as a team. And I think that's really what we're trying to do with URCAL, is show that their collaborations are essential and they do produce results. And I think what I saw this evening and what I heard from so many people is that you're making great progress. And as I've mentioned several times here, even here in the United States, where we started talking in 1975, and it took us 8 years till we got our legislation, and that was in 1983. So it is a long time. And then even after the regulation, after the legislation was passed, I think it was another 12 years till we got our implementing regulations that the Food and Drug Administration agreed to. And so these things do take time. And I think what you'll see with your national plan as well, with the experience of so many other countries, is it will take time, and there'll be pieces that will be done here and there, but you just have to keep moving forward with your planning and implementation schedule. And hopefully that there'll be enough resources financially, personnel, with the stability of personnel to move the national plan forward, to implement it for everyone. So if it's okay, I think we will end the session. And
just a minute. 1 minute, please.
Okay, Luis, go ahead, please.
Steve, excuse me, I'm going to make it in Spanish.
Sí.
Es para recordarles que la próxima semana, el jueves, de 11 a 12:30, tenemos un seminario sobre legislación y planes que vienen justo a contestar muchas de las preguntas que surgieron hoy, que han surgido en las presentaciones. Están invitados Roberto Giuliani de Brasil, Juan Francisco Cabello de Chile y Manuel Saborío de Costa Rica, quienes presentarán la legislación y planes que hay en esos países que en cierta forma han liderado muchos de estos aspectos en Latinoamérica. Me parece que es una magnífica oportunidad para encontrarnos y redondear estas discusiones. Están todos invitados personalmente, y que a través de ustedes podamos hacer llegar a todas las asociaciones de Perú o todos los contactos que tengan esta invitación. Tendremos traducción simultánea, las presentaciones se harán en español, pero habrá de traducción simultánea al inglés. Están todos muy cordialmente invitados. And thank you very much, Steve.
Perdón, doctor. ¿Cómo podemos encontrar información sobre el Congreso?
Yo les hago llegar, si Steve me hace el favor y me envía los correos de los que están presentes, yo les hago llegar personalmente en la mañana la invitación para que se registren. Les vamos a rogar el favor que se preregistren, porque como va a haber traducción simultánea, el contrato de los equipos y demás se hace con base en el número de personas que estén registradas.
Okay. And Luis will tell me all about this tomorrow. People are leaving now, so muchas gracias, and have a good evening. Buenas tardes, buenas noches.
Thank you.
Gracias, Steve.
Buenas noches, Steve.
Gracias.
Muchas gracias.
Buenas noches.
Thank you very
Gracias,
much.
Steve.
We enjoyed a lot. Thank you. We keep in touch.
Gracias, Doménica.
Grazie.
Bye.
Ciao.
Hasta luego a
Chao.
todos, Cecilia, adiós.
Chao, doctor Barrera, qué gusto de verlo.
Chao.
Siempre muy grato verla. Hasta luego a
Chao.
todos. Adiós.
Chao.
Doménica.
Ciao,
Okay.
ciao Luis.
Bye-bye.
Ciao Steve.
Bye bye.
Fuerte
Bye.
bien, Doménica.
Bye.